Welcome to Legal Nurse Podcast. This is your spot to get inspiration, tips, stories, and guidance to help you in your legal nurse consulting practice. I'm Pat Iyer, the host of Legal Nurse Podcast since 2016. We are among the top 5% of all podcasts in the world in terms of longevity and sharing information consistently week after week with legal nurse consultants. Sit back, relax, and enjoy the show. Welcome to Legal Nurse Podcast. I'm Pat Iyer. Today we're going to focus on an area in healthcare that is a focus for litigation, and that is what happens in the operating room. It's somewhat mysterious for us who are not part of the OR staff, what goes behind those closed doors and what occurs in those areas. And we know that there can be cases that arise from injuries that take place in the operating room. I brought with me a nurse who has extensive experience working in that setting. She is trained across all surgical specialties, including open heart, neurosurgery, ortho, general, urology, and more. And her favorite cases are neuro and open heart, probably among the most complex surgeries that I can think of. I had a husband who had a triple bypass with a big incision down his sternum, and I know how much was involved in his care afterwards.
Yes.
And the fact that he was out of bed the next day was simply amazing. When Karen is not on this podcast, she is chasing after her rambunctious toddler, and her 7-month-old is giggling at what his sister is doing. Karen Vacca is my guest today. Karen, welcome to the show.
Hi, thank you for having me.
I wanted to focus on one of the areas that comes up, which is people who wake up from surgery and there is some disruption of their skin integrity. Let's talk about how the OR nurse might get involved as a defendant in that kind of a suit.
So it's very important that there should be a preoperative skin assessment done before surgery because that creates a baseline of comparison to the post-operative skin assessment. And by conducting such, you are able to identify individuals that are susceptible to pressure injuries and then implementing interventions to prevent those injuries. So by doing a visual assessment of patient's skin, bony prominences, body surfaces that experience pressure, friction, or shear forces during the procedure can help guide interventions to reduce those risks.
So we're talking about a skin assessment, and I'm sure it would raise questions in our listeners' mind about how extensive is that? Is that literally for every patient head to toe? Or are there certain surgeries where you wouldn't look at the entire body?
Well, it's going to be according to the way the patient is positioned during surgery. So you want to try to do it at every situation possible because as you are positioning the patient, you are assessing their skin immobility. And surgical positioning creates a risk for skin breakdown and pressure injury development.
I know that it often is a question in attorneys' minds of who has the responsibility for this? Is this a nursing responsibility? Is it a responsibility of the surgeon? Is it a responsibility of the anesthesiologist? Where does the scrub tech come in? Who gets involved in looking at the position of the patient or any padding that might be used?
Well, that's a loaded question. So positioning is actually the responsibility of all members of surgical team. There are goals that we need to do to help prevent any type of injuries. And then the goals of positioning, you want it to provide exposure needed for surgical sites. So the surgeon needs to have awareness of proper positioning for their surgical site that they're going to be doing. And then you also want to maintain patient's comfort and privacy. You want to collaborate with the anesthesiologist to make sure that they have access to the IV lines and monitor equipment. You want to allow optimal ventilation by maintaining patient's airway and avoiding pressure on the chest or abdomen. You want to look through the whole head to toe and maintaining circulation and protecting muscles and nerves, bony promises, joints, skin, vital organs from injury, and then also trying to stabilize the patient to prevent unattended shift or movement during surgery.
So an attorney might hear from the surgeon who would say, by the time I got in the room, the patient was draped. I couldn't see what was going on under those drapes. And of course, I'm sterile, so I can't lift up the drapes or look at padding. How would the responsibilities of the surgeon come into play, if any, related to the padding part of that?
So there are built-in templates according to service and surgeon's preference, and the nurse can edit and adjust those positionings um, if things become different than what is recommended. And you want to verify with your surgeon, is this positioning appropriate for you to do your surgical site? So even if they do come in hands up, ready to scrub in, you need to verify with that surgeon to make sure, is this what you're looking for? And also in charting, you also want to document who was involved in positioning because at the same time, you want to make sure that there was an appropriate amount of team members in assisting the transferring of the patient to and from the OR bed. And then lastly, you want to verify that the positioning was appropriate, like I mentioned earlier, from the surgeon and anesthesiologist.
If a legal nurse consultant who's not worked in the OR is looking at that medical record, what kinds of phrases or concepts would they be searching for related to the padding and positioning standards that we're talking about?
Well, there is, like I mentioned before, a template of positioning and how it is documented, and if there were additional padding that was necessary used. So, for instance, if you have a patient that is overweight, did they use additional pillows, additional foams around the certain areas that are needed for the positioning? If the patient has a history of, say, of immobility of moving the left shoulder, were they able to move it appropriately or did they have to guide it in such a way?
Now, when you say there's a template, I'm thinking, is this a stick figure? Is it portions that the nurses would check off? What kind of wording would they be searching for in the medical record to show that the providers were thinking about or acting on the need for padding and positioning?
Well, there are a lot of checklists to the OR documentation. And under positioning, like I mentioned before, surgeons have a preference in the way the patient should be positioned for that surgery. So, for instance, in spine cases, patients are most often in prone. And depending on the specific type of bed that the surgeon likes to have, then you could add or modify that if needed. And then there's always a comment, adding a comment of, again, who was involved and or if you needed to adjust the positioning or adding more padding to it.
I think about these surgeries, Karen, that can go on for hours and hours and hours. Part of what I've done helping attorneys looking at the pain and suffering that a person experienced during a course of medical treatment has been creating a chronology or a timeline showing the number of surgeries and how long the patient was in the operating room from the point of being wheeled in to the point that they left. And I've been amazed by 9, 10, 12-hour surgeries, not only from the standpoint of the patient laying on their back, but also it must be really hard to be an OR staff to be on your feet that long. And I know that there's change of shifts, but the surgeon is there standing for hours and hours and hours unless being relieved. But putting that aside, what can you do in a prolonged surgery? Maybe it's a complicated procedure. Maybe there are complications that make it more complicated. Is there any expectation that you're going to be changing something in the midst of a really long procedure like that?
So you want to observe. Observe how the patient is doing as best as you can underneath the drapes. Obviously, you can't look completely underneath the drape because you don't want to break sterility or tell the surgeon to stop what he's doing. But you want to make sure how long have they been in a certain angle? For instance, if they were in lithotomy and stirrups, how long were they in stirrups at a certain angle? Do we need to decrease the angle a little bit to help relieve some pressure? Or if they were in Trendelenburg, same thing, maybe raise them up a little bit so they're a little bit more of a flat plane. You want to walk around and observe how is everyone standing against the patient. A lot of times nerve injuries can happen by just leaning up against the patient. So how are the scrub techs? How are the surgeons standing? How are the equipment being used on the patient as well? Every surgical patient is at high risk of developing pressure injuries because of immobility and the lack of sensation during the course of surgery. So it's also important to know what is their history and what is the type of environment, clinical environment that you're providing for that patient.
Yeah, and I'm thinking as you're saying that I've seen some cases where people have been injured from the surgical staff leaning on the patient or placing their arms on one of their limbs in order to do the surgery. I also think about people who've got abdominal injuries where, you can't just say, well, let's roll them on their side and finish the operation that way to get them off their back. Hopefully those are not real long procedures, but the more involved surgeries, like you've talked about with neurosurgery, for example, where they might be doing several levels and the person is on their back or laying on their stomach for an exposure on their back, they can be putting pressure on their face or on their shoulders from that type of prolonged surgery. And I'm sure as you've been talking with me about it, we've been thinking about those long operations and what that means. Part of the answer might be what type of surface are they lying on? How is the technology working to keep up with this issue?
So the National Pressure Ulcer Advisory Panel recommends pressure redistributing mattresses, and that's what's most common in the operating rooms. And that's your viscoelastic foam type of beds, aka memory foam. And there are other mattresses and types of paddings that can be used in addition to. So another one is the viscoelastic polymer, which are going to be gel overlays, and then other types of foam overlays.
I know memory foam. I've run into that in the showrooms of companies that sell mattresses. My recollection is that memory foam has a very high price tag associated with it when it's directed to consumers. People who have memory foam mattresses for their everyday sleeping swear by them and say that they are wonderful and comfortable and all the things that justify their high price tag. So that connects with me in terms of what I know about mattresses. Those types of mattresses are a wonderful thing if your company, your hospital has the ability to invest in them. For some of our listeners who are tuning in from parts of the world that may not have those resources, is there anything that they can be doing?
Oh, well, I mean, from my understanding, this is what is recommended for the OR. And also, these are types of mattresses that work well with X-ray as well. because we do take a lot of x-rays. So you have to be mindful what type of beds you're bringing into the operating room if you need to use x-ray. Is it visio-opaque enough to be seen, whatever you need to view?
Hello, are you looking to become a legal nurse consultant? Are you looking to expand your practice if you already have one as a legal nurse consultant? Well, I'm here to invite you to our LNC Success Conference that is being held November 13, 14, 15, 2025. This is our 12th LNC Success Conference. Pat Iyer and I are both past presidents of the American Association of Legal Nurse Consultants. And as such, we have so much education and training that we want to share with you and with your LNC colleagues. You will have the opportunity to network with LNCs and other disciplines from across the United States, east to west, north to south. You will learn about standards of care. You will hear about medical malpractice cases, personal injury, and you will have the opportunity to speak with a physician, advanced clinicians, as well as others, and ask your questions, your burning questions on how to be a legal nurse, or perhaps how to advance your career. You will have the opportunity to network, as I mentioned before, and you will be going into breakout sessions and working on special assignments. You will do this not alone, but with your LNC colleagues, and you will learn together and have the direction from very seasoned LNCs. So please join Pat Iyer and I. As I mentioned, we're both the past presidents of AALNC, and expand your mind, expand your career, and expand your practice. So join us November 13, 14, 15, 2025 from the comforts of your home or your office. This is a virtual conference. We look forward to having you join us. Please look at the link below, lnc.tips/NOV 2025. We look forward to joining you.
That's a great point. I know that certain people are at high risk for pressure injury. We've talked about the prolonged operation, but are there other categories of patients where people are particularly prone for skin breakdown from the surgical suite?
So a lot of the pressure injury varies according to extrinsic factors, which I've talked about, of shear forces, maybe prolonged procedure time, but then also intrinsic factors, which includes patient's characteristics. So that's going to be skin integrity, like if they have poor skin turgor, a body mass less than 18, being over the age of 60, history of diabetes, of smoking, just to name a few.
And is there within the OR world a recognition and a consideration of these risk factors when somebody is being prepared for surgery?
Yes. So that is discussed with the surgical team if we need to add more padding or an additional extension of the bed if, say, they're very tall, 6 feet or longer. There are extensions that we can add to the beds.
I'd like to shift our focus into an area that certainly can affect skin integrity as well in the operating room, and that's the risk of a fire. We've been talking up to this point about pressure injuries damaging the skin. A fire is one of those horrible events that everyone works hard to prevent. And yet people in the OR are at risk for fires, for being burned, staff as well as patient. What factors in the OR make this such a potent risk?
So for a fire to happen, you need to have 3 elements known as the fire triangle to be present. So that is going to be your fuel, your oxidizer, and your ignition sources. So a fuel can be alcohol-based skin antiseptic agents, drapes, endotracheal tubes, gowns. Your oxidizer is going to be from the anesthesia machine. And ignition sources are going to be your equipment, like drills, lasers, electric cautery devices, fiber optic light cords, and sometimes instruments. And you want to break the contact between fuel and ignition sources to help stop a fire to happen.
That's a pretty scary list, Karen, because
Yeah.
all things are essential, aren't they? And they're all present.
They are.
Given the fact that we've got this nice little triangle that can burst into flames, what do the OR staff do in order to prevent fires?
Yeah, so there are a few different types of examples. So, for instance, using saline, sterile saline to cool down devices when they're being in use because they create heat. So, we're talking about your drills and saw blades. Allowing proper set time for cement to solidify or mold before using electrocautery. Checking anesthesia circuits to make sure that they're free of leaks. Because if there is a leak, then the oxygen concentration increases underneath the drapes.
Mm-hmm.
Also want to prevent pooling and soaking of flammable skin antiseptic agents, and then also allowing them to dry completely before applying sterile drapes.
All right, so you got my attention with that last one for sure, because part of what I know happens in the operating room, and legal nurse consultants may have encountered this, is the production pressure. Let's get them in, let's get them out, let's get the next person in, let's get that person out. Come on, come on, come on, let's get going. I have heard of surgeons who have gotten caught up in the motions of getting through surgery as fast as possible. Not just the risk of fire, but the risk of a complication, severing an artery, piercing a vein, because we need to get done. We need to move along. Tell us about what happens from your perspective, working in the OR. Have you ever seen the kind of behavior that I'm talking about? And then what happens when you see the pressure to move quickly and you've got pooling liquid that has to dry completely before the drapes go on?
Well, yes, you know, the OR can be very tough with all these different types of personalities. And that's why it's very important that we need to step up and speak up. We are the patient's advocates. So it doesn't matter if he is in a hurry or if they are late for their clinical appointments that they have. And if there is pushback, you need to escalate. You know, there is a reason why there is a wait time. These are the risks that we don't want to happen. Um, all I gotta say is you gotta have thick skin and you need to speak up. That's very important. And patient is first.
Yeah, and that's a great point, Karen, because the patient is under anesthesia, cannot raise their hands and say, "Excuse me,
Right.
I need attention here. Let's not push through my surgery. Let's make sure that all the steps are followed." My mother had a wedge resection in her lung when she developed metastatic colon cancer. As a nurse, she knew there was a risk that they might operate on the wrong side of her body. So she went into the OR with a handwritten sign that said, "It's my left lung, please." And the nurse said, "Oh, aren't you cute?" And she said, "No, I'm cautious." Not everybody has that ability to even think in those terms, as my mother did. And they did operate on the correct lung. Thank you very much.
Goodness.
But as that patient advocate, tell us a little bit more about those prep solutions. You mentioned the risk of fire. Can you give our non-OR nurses an understanding about the prep solution's role in creating an environment where a fire could occur.
Yes. So generally, ChlorPrep is one of the most popular types of prepping solution. It's considered the most effective in preventing surgical site infections. But because it has alcohol, it's flammable. So making sure that it dries completely helps prevent the accumulation of fumes underneath the drapes and also the effectiveness of the prep. So it's important to follow the manufacturer's instructions and proper application and usage.
And are there any other risks associated with those prep solutions other than the risk of a flame?
You want to assess if the patient has any allergies related to PrEP solution. So if they have any skin reaction to chlorhexidine, which is in the ChlorPrep, or betadine. We also have different prepping solutions that contain betadine. And you want to assess if the skin is related to the surgical site. So if there is an open wound, or if the surgery is going to be in the mucous membranes, like the genitalia area, eyes, ears, mouth, using a PrEP solution containing alcohol is not recommended.
So I'm aware of fires that have occurred in the OR that involve the head and neck, where the patient was wearing an oxygen cannula and then the prep solution was put on their skin. And then there was a source of ignition, like an electric cautery device. And then all of a sudden you have a face in flames. Can you comment as we close off the podcast about what a legal nurse consultant might look at in that type of a situation?
There should be a fire risk prevention protocol that is done, and there should be a checklist of did they allow proper time of the prep to dry. So you're going to be looking at what time they did their timeout, what time they did the incision, and what time they prepped the patient, and if there was a significant time that allowed the prepping solution to dry.
How long does it take for a prepping solution to dry?
ChlorPrep has a minimum of 3 minutes.
Okay, that's
So
good to know.
yeah, so sometimes we are standing right there looking at the clock, waiting for that 3 minutes to finish.
Mm-hmm.
And then if you have a good surgical team, you have a scrub tech that will not start draping until those 3 minutes are up. Or if there is still pooling showing, then we wait more time.
Okay, and then I can see that's where you could have an anxious surgeon wanting to get started before the time permits them to start.
Yes. And they have information and they are well aware of what these prepping solutions contain and what it needs to be done.
Being aware of what you should do and actually doing it may not be the same.
Yes.
Karen, how can our listener find out more about you and the services you offer?
I am on LinkedIn, so you can find me on LinkedIn with my name. And then my email address is kvaccalnc@gmail.com.
And do you provide services as a perioperative expert witness?
I do.
All right. I appreciate your time, Karen. You've shed some light on what goes on behind those doors. I want to make sure that if I ever have surgery again in my life, that my surgeon is taking the time to make sure I'm positioned properly and not picking up that cautery instrument or that scalpel or whatever is going to give that flame before the prep solution is dry. You've shared with us some of the risk factors that we should be concerned with and some of the things that we should look for in the medical record as legal nurse consultants when an attorney comes to an LNC with a case involving improper padding, prolonged surgeries with nerve injuries or with skin damage, and certainly the horrendous case of the fire is going to require a careful review about what went wrong there.
Thank you for having me.
Thank you for being a guest on Legal Nurse Podcast. And thank you to you who's been listening to this or watching it on our YouTube channel, which is Legal Nurse Business. We now have on podcast.legalnursebusiness.com a way for you to get transcripts and links to audio and video files for our past podcasts. This is our going on 10th year of production of the podcast. And we have organized all of the past podcasts into categories to make it easy for you to find specific information that you are looking for. That is on podcast.legalnursebusiness.com. You can sign up to have access to the vault, and then you can browse through and find past shows of interest to you. Be sure to hang on for another couple of minutes to find out what's coming up on our next show on Legal Nurse Podcast. In this episode of the Legal Nurse Podcast, I'm sharing how to build visibility, confidence, and the connections that bring you cases as a legal nurse consultant. You'll hear real stories from nurses who got their first cases in unexpected ways through family, networking events, random phone calls, even newspaper ads. Their experiences prove there's no single right path into this field. We'll talk about the myths of quick success, the truth about persistence, and the importance of knowing your value as a nurse. You'll learn why attorneys need your skills, how to expand your sphere of influence, and how networking can open doors you didn't even know existed. And finally, I'll share some strategies for staying motivated and supported so you don't have to build your business alone. If you've been wondering how to land your first case, grow your confidence, and connect with attorneys, this episode will give you the inspiration and tools to take the next step. Thank you for being part of the Legal Nurse Podcast audience. I'm delighted that you've joined us for this episode. Be sure to go to legalnursebusiness.com and get your free reports, look around the website, pick up some tools that will be useful for you in your legal nurse consulting practice. And be sure to join us for the next episode.